Hi, I'm Matt Collins, and today I'm going to be performing a respiratory assessment and all the skills associated with it. Hope you enjoy. The respiratory status assessment is an integral part of every assessment performed on any patient, but especially respiratory distress patients. It allows the microparamedic to gauge the severity of the respiratory distress by individually assessing different points of the respiratory status assessment. As I walk up to the patient, I try and gauge the patient's appearance, whether they're calm and relaxed, to anxious, to catatonic. Here I try and assess how well they can speak in full sentences or in words only. By unzipping the patient's jacket, I can determine the patient's work of breathing and their effort. Counting the respirate can assist me in making a diagnosis. Chest auscultation is integral to any RSA. Removing the patient's jacket and trying to listen to the chest on direct skin wherever possible. Listening at 6 points with 2 ventilations at each point. Whilst doing chest auscultation, respiratory rhythm can also be assessed for prolonged expiratory phases, for example. The last couple of assessments of an RSA include the pulse, checking for the patient's skin, and whether they are alert or not. To perform my airway assessment, I'll utilise the triple airway manoeuvre. I'll place a towel underneath the patient's head, then utilise the head tilt. I gently apply pressure to the patient's forehead and tilt the head back. I use the chin lift by grabbing the chin and lifting it forward gently, and then placing my little fingers underneath the edge of the jawbone to raise the jaw. To perform laryngoscopy, you need to put the patient's head into the optimum position. This is the sniffing position, which can be assisted by placing a towel underneath the patient's head. Grab your laryngoscope with the correct size Mac blade, ensuring that the bulb works and is bright. Place the blade to the far right corner of the mouth, advance in and sweep the tongue to the left as you advance the handle. Advance the blade to the valvular groove. Once here, advance the handle up to the imaginary where the wall and the roof meet in the corner of the room until the cords are sighted. Airways are graded by using the Cormack-Lehane grading system, which is performed with the laryngoscope. It is what you see when performing direct laryngoscopy, and it is more accurate way of predicting the actual difficulty of intubating a patient. It's also used to document how tough an airway is. Airways are graded from 1 to 4, 1 being the easiest and 4 being the most difficult. After advancing a laryngoscope, a grade 1 view is described as the entire view of the glottis. A grade 2 as a partial view of the glottis. A grade 3 you can only see the epiglottis, and grade 4 you cannot see the epiglottis at all. When intubating a patient and being confronted with a grade 3 or 4, this is when you would head down the difficult intubation guideline. The bag valve mask is utilised when positive pressure ventilation is required on your patient. An example of this is a heroin overdose who is hyperventilating. Ventilation of patients with cardiac output should also include the use of a PEEP valve to improve ventilation, alveolar recruitment, and gas exchange. First, I place the patient in the optimal position in the sniffing position with a towel underneath their head. I grab my Liddell bag with the reservoir bag attached already. Then I place the PEEP valve on, set at 5 centimeters of water. Then attach my end-tidal CO2, bacterial filter, licorice stick, and then the face mask. I place the mask over the patient's mouth. To ensure adequate seal, I place my thumb and index finger around the face mask and my 3 other fingers around the edge of the mandible, with the ends of my fingers up underneath the edge of the mandible to ensure adequate seal. I look, listen and feel for rise and fall of the chest. To troubleshoot, I can use 2 hands for adequate seal with 2-person BVM, and with a beard I can use some lube. The nasopharyngeal airway is indicated in patients who are unconscious and have trismus, or the patient who is unable to take an OPA but needs airway securing. NPAs are contraindicated with patients who have middle third facial fractures, significant nasal trauma, a traumatic brain injury, where the airway's pain and vital volume is adequate but despite trismus. Precautions include base of skull fractures, CSF from the nose and ears. For NPA insertion, select the appropriate airway by measuring from the corner of the nose to the earlobe. The diameter of the NPA should be slightly smaller than the nostril opening that you pick. Apply lube to the NPA. Inspect nostrils for any obstruction and select the widest nostril. When inserting the NPA, push the NPA into the chosen nostril 90 degrees to the patient's face. At this stage, any resistance, stop, do not force, and pull out. Here we are, advance the NPA, rotating clockwise, anti-clockwise 45 degrees whilst inserting. If there's any further resistance at this stage, re-lube, try another nostril, or select a smaller NPA. Insert the NPA to the measured length. From here, apply your BVM, gently assist some ventilations if required, and look, listen and feel for chest movement for adequate ventilation. The oropharyngeal airway is indicated in the unconscious patient to maintain forward displacement of the tongue, and also as a bite block for intubation placement. Contraindications include the gag reflex and patients with trismus. Measure the OPA from the corner of the mouth to the corner of the jaw. You can lubricate the OPA with water or the patient's saliva. Hold the OPA natural curve upside down. Pass the tip first and insert halfway into the mouth. Rotate 180 degrees. Insert until the flange rests on the patient's lips. Then you look, listen and feel for air movement. The LMA provides improved airway and ventilation management compared with a face mask and the OPA. The LMA does not protect against aspiration and therefore inferior to intubation. Things to consider when inserting an LMA. Precautions are the inability to prepare the patient in the sniffing position, patients who may require high airway pressures, patients who are less than 14 years of age due to enlarged tonsils, and significant volume of vomit in the airway. And the LMA, even though with correct placement, does not prevent passive regurgitation and gastric distension. Ensure the mouth opens 3 finger widths. Select the appropriate size eye gel. Remove from the packet and lubricate the posterior aspect of the eye gel. Advance the eye gel in through the mouth over the top of the tongue, pushing the back of the mask against the hard palate. Glide the eye gel downward and backwards along the hard palate with a continuous but gentle push until a definitive resistance is felt. The eye gel will rebound a little bit. Once in place, secure with tape or cloth and then ventilate, ensuring for adequate placement. Thank you for watching my respiratory assessment and associated skills video.